Okay. So quickly about me, I'm a retired deputy fire chief from Orange County, Florida. We're the area around the city of Orlando and Disney World, a metro agency, 41 fire stations, 1,100 firefighters. I retired from there in 2008. I've done other things. Like many of you, I've had quite a mixed public safety career doing different things. I'm a volunteer in the ED at Harborview, where some of you may have seen me, although we were all kicked to the curb March of last year because of COVID, and hoping to come back. I started my EMS career back in 1974. I'm that old. First as a volunteer in a hospital. We were using glass IV bottles, and on the left side, that's a giant, almost 100-pound AC powered defibrillator there. And then in my EMS career, we had very rudimentary patient care equipment that I'll talk about later as we go through the history of EMS. Just a couple of funny things. I think even Dr. McCoy and Dr. Sayer don't know. I used to compete in rodeo in my youth. I was a professional calf roper. And I've also been a full trauma activation patient twice. This was when a drunk driver broadsided my police car. So I've been on both sides of the stretcher, or in this case, both sides of the backboard. So today we're going to talk about the history of EMS communications, how we got to where we are, look at the call flow of how EMS calls flow today, how we think they will flow tomorrow, and then talk about some regulatory and policy issues. You know, how is all this managed, and end with some important takeaways. I would say two things. One, my presentation has some technical detail in the slides, and don't worry about that because I'm going to make fun of all of that. So, and the second issue is that Seattle is really an anomaly of excellence when you look at EMS. And so as you think about EMS communications, it's very important to not really think about the Seattle experience, if you will, to think about how things are done elsewhere. So we start off by saying, what should EMS medical directors know about emergency communications? It's a complex topic and sometimes a scary topic. And most medical directors are very comfortable in this space, you know, the clinical space, talking about tension pneumothorax and pacemakers and things that all relate to clinical trials and clinical outcomes. But from a medical director perspective and EMS communications, we know that the AHA chain of survival has all sorts of very important links that relate directly to the communications center. And medical directors play a really critical role in helping develop those systems of care that occur in the moments after 911 is dialed, and in managing the ongoing operations of those. And I'm not going to spend time talking about this particular slide because I could actually spend an entire hour talking about that slide, and I would get in trouble. So if you're an EMS medical director, there's some really important things to think about, and many of them are non-clinical. They relate to clinical, but they're not clinical. And this is why it's important to understand them and to have liaisons with people who can help tease out a lot of these issues. But the first issue in EMS communications is, you know, how does someone report a medical emergency? What happens at the moment someone collapses at Fred Meyer, and how does the medic unit even know that incident has happened? And so if you have a good QA/QI program and you have insight into what happens, you can learn a lot about time lapses that occur, how long it takes a 911 call to actually reach an EMS dispatcher, how long does it get delayed by the police dispatcher before it comes over, what technologies are used to alert both first responders as well as other responders, as we do here in the Seattle area. And then the second piece of EMS communications is all about how well does the communications work among the EMS components? How can EMS units talk to other EMS units? How can they talk to other public safety agencies like law enforcement if you need clearance to enter a violent crime scene, and especially with hospitals? And so if you have radio dead spots where EMS units can't communicate with medical control, If you have different issues where you can't always talk to all the hospitals you transport to, as you do case studies, you can find lots of irregularities in patient care that you can tie back to some of these issues that involve the communication center. So we can't talk about the history of EMS communications unless we talk about the history of EMS. And the history of EMS really starts back in the time of funeral homes. And here is an ad from the telephone book from probably the 1960s or early 1970s for the Schwartz ambulance service, saying that you can call them for prompt, courteous, efficient service for emergency or invalids, right? But in the 1960s, funeral homes were the predominant provider of EMS services. There were some pockets of excellence around the US, likely right here in Seattle, but many patients were taken to the hospital in a private car, and funeral home ambulances were more likely to be called for major emergencies, including traffic accidents. And there's a big focus on traffic accidents we'll talk about in a minute. And there was no perceived government mandate to be involved in EMS. No one was interested or curious about regulating it. So almost anyone could say they provided ambulance service. And so funeral homes saw this as a what they call a complementary service offering. If you called the Pavlik Funeral Home and needed an ambulance and the patient survived, that was great because the family was happy and they would probably call you when their loved one eventually died. But more commonly, if the patient died on the way to the hospital, hey, the Pavlik Funeral Home just sort of diverted from the hospital and went right to the funeral home, and they got the business, right? So a rather conflict of interest scenario here. All this started changing in the 1960s, fortunately for us. And in 1965, the President's Commission on Highway Safety issued a really significant report titled Health, Medical Care, and Transportation of the Injured. And in this report, they looked at highway traffic fatalities, which was a really growing crisis in the US. And they determined that timeliness and adequacy of care was a critical deficiency across the entire US relating to EMS. A year later, the National Academy of Sciences published a follow-up report that was even more damning, if you will, of EMS in the country. And you can see from the list of items here that this pretty much told you how EMS operated. No treatment protocols, nobody was really trained. There was inefficient transportation. You couldn't carry equipment on a hearse. You couldn't really do a lot of patient care in the back of a hearse. There was no communications equipment to talk to anyone or even to let the hospital know you were bringing someone in. And again, they found that local authorities had no interest in really doing anything with this. And finally, for Dr. Sayre's benefit, the lack of research on pre-hospital care was also noted as a problem. So the federal government took action, and in 1967, EMS, then ambulance service, was assigned to the Federal Department of Transportation. And you would say that's an odd place for EMS to land, as in DOT, with all the snow plows and interstate highways. But at the time, ambulance service was viewed as a transportation problem, not as a patient care problem. And so from 1967 all the way to today in 2021, DOT is still the federal coordinating agency for EMS under the National Highway Safety Traffic Safety Administration. And interesting, DOT also runs the National 911 Program Office. So you don't really think of DOT as being a big impact in EMS, but it really is. So we're going to talk about two components of EMS communications. The first component is calling for help. How do people tell us they need help? And the second component of communications is how do we respond? And so let's talk about how the public accesses help. This is a picture of the City of Seattle ambulance in 1921. In 1921, funeral homes did provide ambulance service, and the City of Seattle had a single ambulance for the entire city. And that's a picture of it right there, I think, down on Pike Street. So in the 1960s, if you had a medical emergency, if someone had a heart attack or fell off the roof or a seizure, you would run to your phone book and you would flip your phone book open to ambulances in the yellow pages. and you would try to find yourself an ambulance, and you would look there and you would see you could call the Capitol Funeral Home or the Mitchell Funeral Home. You probably didn't know any of these funeral homes, but you would dial one of them for an ambulance. And you can see in the middle, these are all ads of the phone book. You can see that Wilson, North Carolina, the middle image, they're North Carolina's newest and finest colored funeral home. So you had colored ambulances and white ambulances, and you had to call the correct funeral home to get the correct ambulance to come to you. And the ad on the right with Apex Funeral Directors, you see that they have 24-hour service. Not all these places offered 24-hour service. And each car had oxygen. That was a big thing. If you were in a metro area, Los Angeles, New York, the inside cover of the phone book looked a little different for you. And this is the Orange County, California phone book. The right side image is the full page, and I've blown up some of it on the left side. So if you were in Orange County, California, you would open the phone book and you would just see a dizzying array of fire departments. And you would have to figure out, where do I live and which fire department is mine? And you may call the fire department, and the fire department may not provide EMS. They may tell you, we don't do that. You have to call somebody else. Or they may tell you, no, you're not in the city of Balboa Park, you're outside, right? So it's very problematic for people to figure out who to call and how to get help. By the 1970s, the inside cover of the phone book changed, and they said, you know what, people, figure out the number yourself and just write it in on the front cover. And so the front cover of most phone books had a place for you to hopefully research in advance and put in numbers for police, fire, ambulance, and even there at the bottom, doctor, and it shows a picture of a doctor with a bag running to their car to come to your home. Interesting. Or at the bottom, it says you can dial operator and say, I want a resuscitator, and give them your address, and the operator would find a resuscitator, whatever that is, right? So things get dramatically better in the 1980s. And in the 1980s, 911 is starting to proliferate across the country. On the left side of the image in the red box, you see a cord board switchboard. If you've ever watched Lily Tomlin play Ernestine on Laugh-In with the switchboard, you know exactly what a cord board is. But 911 service just provided voice contact, but it was a paradigm shift that people could dial an easy, recognizable number, and the 911 operator would find the right people to give you help. In the 1980s, we went to Enhanced 911, and Enhanced 911, we got all the data associated with your call. We know we got your name, your address, and your phone number. So if you dialed 911, and you needed help, we could get it to you much more quickly, especially in cases where children dialed 911 and didn't know their address, or you had people who were elderly and confused. I worked for the city of Gainesville, the Gainesville Fire Department in the 1990s. And on the first day we turned on this system, a man dialed 911 and he was choking on a hot dog and he couldn't talk. He could only gag into the phone. And we used the address on the 911 screen and dispatched the fire department, and they arrived in time to save his life. And if he had choked on that hot dog one day earlier, we would have had no clue where he was. So things in the 1990s are looking really good in how citizens can access EMS and how we can find people quickly. But by the 2000s, cell phones were becoming in widespread use, and cell phones also created a real paradigm shift in detection and alerting of emergencies. The public can call us instantly when something happens. And this is especially important if you think before cell phones. If you had a bad car crash on an interstate highway, someone would drive to the next interchange and try to find a store or a payphone to call for help, and a tremendous amount of delay. So cell phones were another huge improvement for EMS in allowing us to know about calls earlier. And the improvements in location technology have also been occurring very rapidly with cellular calls. I'm not going to go into details, but as of 2020, the federal government mandated a new standard for accuracy. I know many of you are dispatched to calls where the dispatcher will tell you the cell phone says they're near here, and just know that the cell phone is only required to provide accuracy of 328 feet, 70% of the time. So a couple of football fields there. The map you see is the dot. If you're calling 911 from that dot, the dot on the map for the dispatcher may be anywhere in that shaded circle 70% of the time, right? It could be on the next street 3 houses over. So just be aware of that. The federal government continues to try to make that better. And also this year in 2021, there's a new federal mandate that they have, the cell companies have to start transmitting vertical access data. And that's a picture of the Insignia condos downtown. And you can imagine if Seattle Fire is dispatched to the Insignia and they say, well, the 911 shows the caller is sort of on the north end of the tower. That's not very helpful because you don't know if the patient is on the 1st, 3rd, or 19th floor. So with this new accuracy standard, you should know whether the person is on 3 floors. The floor of, above, or below is about what that accuracy is. In the mid to late 2000s, we have smart watches and all sorts of consumer health data. And we have all these devices that can call 911 for you without you even asking it to, right? So fall detection, watches can do seizure detection and do alerting for seizure detection. And Apple Watch is actually about to release a new watch that will do continuous glucose monitoring all through your wrist. And Samsung is waiting for blood pressure approval on their watch. So watches and other devices, they also have heart rate alarms. They can alert you for high and low heart rates. So, so there's lots of new ways that EMS can be alerted to calls that is sort of on the horizon for us. Watches today, the Samsung watch can do your blood pressure after you calibrate it once with a blood pressure cuff. This is approved in Korea. Samsung is currently going through FDA approval for the US. You can do your SpO2, you can do a single lead EKG. Your phone will even transmit a PDF file of a single lead EKG to your physician if you want to do that. And all of these watches are capable of transmitting this data directly to the 911 center, although we're not doing much of that today, but that's on the horizon. So from the 1960s to today, the big key takeaways are we have nationwide access to 911. We have location data being transmitted with that call that's getting better every couple of years. We have lots of mapping solutions now that show us where our vehicles are, where the emergency is. Cell phones have really accelerated detection and alerting, and we have devices that are automatically calling for help. The second wave of EMS communications is about how do we talk among ourselves? How do we communicate? And so in the 1970s, and first that's not a picture of me. In the 1970s, most ambulances had a mobile radio in them, and the mobile radio worked very well. We could talk good distances with that, could almost always talk to the hospital. Our portable radios were the size of a lunchbox. They weighed about maybe 20 pounds. They had 2 channels. We could talk to the dispatcher, or we could talk on a hospital channel, which every hospital shared the same channel in a 3-county area. But the range on that portable radio was only a mile or 2. So the patient had to be in the back of the ambulance before you could talk to the hospital. There was no medical control, by the way. You just talked to the ER. On the hospital side, things were just as dismal. Most hospitals had an antenna on the roof, and depending on how high the hospital was, depended on how close you had to be to the hospital to talk to them. So in some cases, the ambulance had to be 3 or 4 miles away from the hospital before they could even radio the hospital and reach them. There was a very common radio channel used starting in the 1970s called HERE, the Hospital Emergency Ambulance Radio. Harborview has this actually in their ER still. And that was a common channel used all across the US. In the 1980s, the federal government allocated a bunch of new radio channels for EMS, including 10 med channels that would allow transmission of telemetry. So we now have these big 40-pound orange box radios that if you ever watched the TV show Emergency, you saw those. And they allowed us to transmit a single lead EKG to the hospital. And they were much more reliable and had a greater range. By the 1990s, big improvements in the actual dispatch center. The radio systems that we use, trunked radio systems, which King County and Seattle use today, And the computerization of EMS dispatch, where resources are tracked, there's algorithms that automatically determine the number and type of units that should go to specific emergency calls. Also in the early 2000s, we had automatic vehicle location and mobile data computers were becoming very common in EMS vehicles. And we were now able to dispatch EMS based on their true proximity to the emergency, not just an area of where they were assigned. And this makes a lot of difference in the rapid arrival of EMS to the patient's bedside. And you see an image there, the computer screen says using distance. It's actually telling the dispatcher that these engines and rescue units are the closest physically to this address, irrespective of what fire station the patient may be near. Again, in the early 2000s, we moved away from single lead EKGs to basically to faxing over cellular and transmitting a 12 lead EKG to the hospital. And also in the early 2000s, we had a lot of advancements in vehicle crash sensor technology. So OnStar, which you've probably heard of, and other providers like ATX have sensors built into the vehicles. And when the vehicle crashes, these sensors transmit a data burst that tells their dispatcher that this car has been in a crash. And a tremendous amount of data is transmitted that rarely ever reaches the 911 center or the ED. The data will tell you if the car rolled over. And if it rolled over, is it right side up now? Is it on its side or is it on its roof? Was it a driver's side broadside impact with the prevalence of major injury? Was it a head-on collision, a side collision? Were the airbags deployed? Which ones? What was the velocity of the impact? Was the car going 10 miles an hour and struck the building in the parking lot, or was the car going 50 miles an hour and hit a bridge pillar, right? And the algorithms also calculate a crash severity rating that takes all these things into effect and gives a score. And that score is supposed to be predictive of major trauma. So this crash notification, very, very helpful in rural areas where you may need to know early on that you need extra resources and you need perhaps extrication. And your first EMS unit or first public safety unit may not arrive for 15 or 20 minutes. And then we go into the rest of the 2000s, and everything is about apps and digital technology. And we see EMS using more and more tablets, cell phones, drones, and other apps like Pulsera. So as we look at EMS communications across the system, we see we've had really improved coverage and reliability. We've had great advancements in how the dispatch center manages the assignment of resources and data. And we now can transmit patient telemetry, not just a 12-lead EKG, but we can also transmit lots of other physiologic data if we think there's a need for that. We also have FirstNet. FirstNet is the nationwide public safety broadband data network. This is like a private AT&T network that is reserved only for police, fire, and EMS, and it guarantees high-speed delivery. So if you've ever been in the radio room at Harborview and the 12-lead EKG never arrived for you to see, that may be because it was a Seahawks football game and the 12-lead EKG for Medic 1 was competing with everybody who was loading up images to Instagram and Facebook. In a FirstNet environment, that would not happen. That data would always go through. So EMS communications today looks sort of like this graph. You have detection where a patient collapses, someone calls for help. That call goes to the 911 network. The 911 network determines where that call will be routed. It automatically routes the call either to King County Sheriff, to Seattle Police, to Valleycom, wherever it needs to go. These calls almost always arrive with a police dispatcher first, and then they are transferred to another agency, in the case of Seattle, to Seattle Fire, for Seattle Fire to take over that call. And all of these little hops inject delays, as you can appreciate, into call handling. So the fire dispatcher, whether it's at Valleycom, Norcom, or Seattle Fire, the fire dispatcher call taker enters that into their computer, and that call pops up on a screen in front of another person, and that person dispatches the call. And so calls are dispatched in a variety of ways using pagers, voice over the radio, voice into fire stations. Lots of things happen to get the alert out to the crews, and the crews respond. Most Vehicles can look at mapping to help them figure out how to get to the address and understand these crazy streets that we have. Um, and most of the dispatch computers and the vehicles show you everything that the 911 operator captured about the patient's problem. You arrive on scene, you can talk to medical control, you can send medical control your EKG, and then you can transport to the hospital. You may alert the hospital you're coming, you may not. Every hospital is different in how they approach what patients should be called ahead. And then finally, you get to the hospital. There are some things in purple I won't really touch on, but quite a few of these things are not common, including transmitting the EMS EHR report, the PCR report to the hospital. That is needed, but not very common across the country. So we look at that. If that's today, what is tomorrow? What does tomorrow look like? And this is an image from the Hunger Games, and who knew they'd be operating a 911 center in the future? But the comm center in the future will look nothing like the comm center as it does today. And the first paradigm shift to be aware of is next generation 911. And next generation 911 is sort of like a tidal wave that is coming very, very, very slowly across the country. But it is a nationwide replacement of an old analog 911 system that's been in place since the 1970s. And next generation 911 will let voice, video, and data be transmitted simultaneously with the 911 call. So that creates an entirely new arena inside the EMS Communications Center, because now the EMS dispatcher today can only hear the caller, and that we have to infer things, and we ask questions because we can't see the patient. And now we will be able to see the patient. We'll be able to see if the caller, are they doing CPR correctly or not? You'll actually be able to see if they're doing CPR correctly, and you'll have an obligation to correct them because you can see what's happening now. You can actually see the stroke assessment. If you want to do a stroke assessment on 911, you'll be able to visualize the patient's face. And also, this also means that EMS dispatchers may also be traumatized because they will now see the patient with a gunshot wound to the head. And all sorts of other nasty things that our EMS crews see, but our dispatchers have been somewhat shielded from. And the NG911 system will also receive data alerts. And so the screen in the middle is an example of a data alert. And this box may just pop up on a screen at Seattle Fire or at Valleycom. And it basically says that the patient has an arrhythmia, and they can click the little view button and actually see a sample of what an image of what that arrhythmia is. And the patient is not responsive, and it gives you their location. You can click the map link, it'll show you where they are. And it tells you that this medical device belongs to a 61-year-old male named Carl Davis and some medical history. And so in this case, Mr. Davis fell over in VTAC. And nobody was around, but his device automatically called for help for him. Also, beyond NG911, drones are sort of a big thing now for everything. I mean, you look at any industry and everyone is looking at how to use drones. And so many public safety agencies are currently using drones for situational awareness. Sometimes even after they arrive at the scene, they're floating a drone up in the air to look at the fire. Some agencies are sending drones to vehicle accidents to get there first and hover overhead and look and see how many cars are involved. Is there entrapment? So from a situational awareness perspective, some really good uses, especially in rural areas for that. And of course, there's the whole issue of cardiac arrest, and can we bring an AED to the patient fast enough for it to make a difference? And this was first started in Europe and now is in North America. So there's a Canadian company that is working with one of the provinces there. They're in the third phase and final phase of doing some testing before they actually start responding drones with AEDs to the scene of cardiac arrests. The dispatch center will actually launch the drone at the time of the 911 call. And Reno, Nevada is also in the middle of launching a new drone AED program. Theirs is unique in that the drone will fly directly to the incident scene and it will lower the AED on a cable to the ground. A lot of the problems in using drones is how do they land safely? So they said, we're not going to land them, we're just going to sort of drop the defibrillator to the ground. And so both of these, but both Canada and Reno, they looked at all their cardiac arrests retrospectively, and they modeled how quickly a drone could arrive at the scene of a cardiac arrest, and they determined that the drone can deliver the AED between 4 and 7 minutes faster than EMS's arrival. So it'll be interesting to watch this. I would note that Dr. Eisenberg, if he was on our call this morning, would be raising his hand, because Dr. Eisenberg has correctly observed we need to see the data before we get all excited about this. From a 911 EMS perspective, drones can deliver blood. Many units carry blood now. It's expensive to carry blood. You got to make sure you're rotating it out. There's all sorts of requirements for refrigeration. A drone could fly blood to the scene, or could fly blood to an intercept point for a medic unit coming in from a rural area. Drone can fly IV solutions and supplies to an MCI scene where you have dozens of patients, or a drone could fly an EpiPen to a school playground for a child who's been stung by a bee. So we see drones as being have a lot of utility from an EMS perspective, from a potential. Beyond drones, sensor-based alerting is really becoming a thing, and unfortunately becoming an unregulated thing. Apple Watch introduced their Apple Watch that automatically dials 911 when it detects a hard fall. The 911 community was not involved in that. Apple Watch just did it, and then we had to figure it out, which is not how you like these things to happen. But lots of improvements here in consumer-based healthcare, and we expect that you will have critical glucose level detection and heart arrhythmia detection notifications coming to 911 centers soon. If you have an implanted ICD right now, it will detect VTAC. It will send an email to your cardiologist telling you that it had that event. Your cardiologist will find that email on Monday morning when they come into the office, and you will be dead, right? So if the device can send an email saying it detected VTAC, it can certainly send a data alert. And Medtronic has actually been in some conversations with us about how that might work. The next issue is artificial intelligence, and how do you have Alexa for EMS? The Department of Homeland Security and some other government entities have been dumping a lot of money into looking at artificial intelligence and how it can support EMS. And one of the prototypes from Homeland Security is a program called Audrey, and Audrey is learning how to listen to EMS personnel talk as they are with the patient, and actually synthesizing their speech and assisting them by transcribing the conversation into the patient care report, by identifying the patient and then going and retrieving all of the patient's health data from a central repository, so you could see the patient's medication lists, look at their last 12-lead EKG, see what history they had. Audrey can also listen and know your standing orders, and she can answer a question about a drug dose. If you can ask her, what is the pediatric drug dose for epinephrine for a child weighing so many kilograms? Or if Audrey hears that the healthcare provider is about to administer a drug of an incorrect dose or an incorrect drug, she can prompt you to reassess. So lots of interest in how artificial intelligence can support EMS. So this was EMS Communications today, how it flows. And so EMS Communications tomorrow is sort of a more dizzying chart. But the yellow is some of the key features that I'm going to touch on just briefly. First, we think that we're going to see a lot of patient emergencies reported by devices and not by the patients themselves. We also see the role of a medical validation server, which is that little thing in the middle there, a little cylinder. And that's the device that would say, okay, the IACD says the patient is in VFib, but the patient appears to be walking and the patient has a good heart rate. So we are not sending this data alert to the 911 center. We're going to have a phone call to the patient to make sure they're okay first. So there has to be a way to screen out false alarms, which is a big concern for everybody. I mentioned about sensor data and video data coming into the 911 center. And that also means, by extension, that that data can be available to crews. And it becomes a question of how much data is too much data, and how much data is really helpful for the crews to know versus swamping them with Mrs. Jones' 200-page medical history, right? But accessing healthcare records either automatically or when necessary would be a good thing. It also allows medical control to receive a lot more data, physiologic data and background data than they probably do today. And obviously you can share that data with the hospital, and hopefully we'll have better integration between EMS's patient care reporting and the hospital EHR. The final future thing I'll talk about is situational awareness dashboards. We see some progressive EMS systems looking at this for both system capacity and also for ED. But this is a mock-up of what a dashboard would look like at Harborview. It would show you, it showed that the triage nurse, every inbound patient coming to Harborview. And this would be data coming from those agency CAD systems, AMR, Seattle Fire, Valleycom, et cetera. And it would just be a single line of who the unit was. Was it adult pediatric, or was it medical trauma? What was the triage code for that patient? And what is their real-time ETA? And so if nothing else, you would really know when the unit would arrive, instead of the medic looking out the back of the rig and saying, I think I recognize that intersection, and telling Harborview we're 10 minutes out when we're really 26 minutes out. Many large systems, they don't let BLS calls to the hospital, right? And from Harborview, we know AMR shows up, and then they show up again, and they show up again, and they show up again. And so we don't have any awareness into how many of them are coming, and that will be helpful from a planning perspective. So a dashboard would just let the triage nurse have a sense of who's coming in. And because all the physiologic data is already captured by the medic and available to the medic, if something happened en route, the dashboard could actually pop up an alert message right below this medic 1 and say, this is a data alert coming from medic 1, and here's what happened. The patient's blood pressure just crashed and they're extremely tachycardic. When a patient condition changes suddenly, if I'm in the back of the truck, I'm working on the patient. I don't have time to pick up the radio and tell you that something happened. You find out about that when I'm on the ramp, right? And I tell you something bad happened. So all of these things are possible with today's technology, actually. So I'll end the future view with that. But let's talk about regulatory, because I want to get through a few things and have time for some questions. We need regulatory to help keep all this stuff in check and to make sure that it is used properly and consistently. And so there are 3 main entities who regulate EMS communications, and we're going to talk about each of those. The first one is the Federal Communications Commission, and if you don't remember anything else from today's presentation, please remember FCC, because the FCC allocates all radio channels for non-federal use. So for us, for public safety, the FCC has to regulate and approve every radio frequency that we use in EMS for anything. And not only do they assign the channels, they also do all of the engineering standards for these radio systems. They have some very complex rules that you will see, like 12.5 kilohertz offset channels for medical telemetry. That means nothing to me personally. And they also assign frequencies, and you can't use a frequency unless it's been assigned for the purpose you want to use it for, like EMS. And it has to be assigned for EMS or public safety use. And so there are dozens and dozens of channels all over the US that are available for public safety use. Locally, right here, these are some that available in Harborview or used here in the Seattle area. And you can see they're all over, right? We have channels in the 155 megahertz for airlift. We have a channel in the 129 aircraft range for the helipad at Harborview, and other channels for hospital common and AMR. And if you pick up your radio, if you're the Medic 1 doc or the trauma doc, you pick up your radio, you're transmitting on a pool of channels that randomize between 851 and 868 megahertz. So if you're ever at a cocktail party, if we can ever do those again, and you want some trivia, ask somebody what frequency they're using. The next issue of regulation comes from the state. Almost all states regulate EMS and regulate EMS communications, typically setting minimum standards for the radio systems that have to be used. And most states set aside special channels for interoperability, for agencies to talk to each other, both on a day-to-day and a disaster basis. In the state of Washington, Washington Administrative Code 246-976-310 sets out specific standards for EMS and says you got to have radios in the front and the back. You got to have a two-way radio communication for medical control and dispatch. If you use a cell phone, like King County Medic units do, you still got to have a radio in case the cell phone goes out. So minimum standards exist across the state of Washington, as they do for all states, almost all states. The final regulatory realm comes at the local level, whether that's the county level, like King County, a regional EMS authority that may be in other places, or even locally in the city. So the city of Seattle, for example, has a contract with AMR for EMS response. And the city of Seattle has regulatory requirements for AMR in order to have that contract. And one, I just picked a random one here from that massive contract, and AMR is required to connect their system to Seattle's AVL so they know where vehicles are, and they are required to put computer terminals in the AVR vehicles. So after regulatory, we have standards, and there's lots of standards. Lots of different organizations create standards. You probably recognize some of these. ASTM is the American Society of Testing Materials. They create standards for PVC pipe, and they also create standards for the thickness of cast iron, and they also create standards for EMS. So you never know where a standard is going to pop up. NFPA is one of the most common ones you probably hear about, the National Fire Protection Association. They have hundreds of pages of standards that relate to emergency response. I'm going to just sample two quick standards that are in use here. One is NENA, the National Emergency Number Association. They have a standard on how fast you have to answer 911. And you would think, well, of course, when 911 rings, it's just answered quickly. But if you're in the Los Angeles area and you dial 911 at 5 in the afternoon, your 911 call may ring for 3 minutes before it's answered by an operator. So speed of answering is a problem. Agencies sometimes don't hire enough people for the call volume they have. So there's a standard, and the standard says 90% of those calls need to be answered in less than 15 seconds, 90% of the time, right? And then 95% of them should be answered in less than 20 seconds. So many agencies adopt the NENA standard and require that their providers and their 911 centers adhere to that standard. The National Fire Protection Association has a standard on processing emergency calls. How fast from the time you answer the call do you alert your crews? What is that processing time and that delay? And this is an interesting standard because this standard changes every 2 or 3 years. You may think you know the NFPA standard, and then you may find out, oh, it changed again. So be aware, standards evolve, and this is one that keeps evolving, and is currently, if I have the right version, and I hope I do, is now at 64 seconds. So you have 90% of the time, you have 64 seconds from the time you answer the call until you get that call out to the first responders for high priority calls, which are house fires, threats of violence, things like that. They have an asterisk in the NFPA standard because medical emergency EMD or EMS calls are called out of the separate criteria, and they're trying to match the Heart Association. We're trying to get those two standards in sync there. So be aware that lots of people have standards. There are standards that are in conflict with each other. It's important to know what standard is being used. Standards can be adopted by governing bodies or even by an agency. Sometimes standards are voluntary, and it means we're going to do our best, but we're not required to. Or a standard can be a mandatory standard, especially when adopted by a regulatory agency. So a state may require that 911 centers comply with the NENA call answer time, or else they can't collect 911 funds. That's the carrot and the stick. That's a very common requirement that we see. So some important takeaways from all of that are EMS Communications is really best managed on a regional basis versus a local basis. And I think here in Seattle, King County, we do that well. As an example, we have Pulsera here, and is Pulsera used? It depends on what hospital you're going to and what unit responded to you. And if if 5 different EMS agencies all got different software for stroke alerts, would the hospitals all install 5 different types of software to communicate with everyone who brings them a patient? And would they know how to operate that, right? So you can see that it's important that individual agencies not say, we're just going to do what we want to do, but they really look at collaboratively how to make this work. It's important to understand what rules and policies and standards are in effect, and if they're mandatory or best practices. It's important to have a relationship with somebody who knows all this radio stuff and who can alert you to changes. The Federal Communications Commission on several occasions has changed rules that have significantly impacted EMS and has impacted existing radio networks that had to make sudden changes because of rule changes. It's important for EMS medical directors to be advocates for proven technologies. And I like to say that medical directors bring an evidence-based mindset, which is usually absent among fire chiefs, to this conversation. And new technology does not always mean improved outcomes. It's also important to know that system cost is much more than the purchase price. Another pitfall fire chiefs fall into, that you give us something free. You're going to give us the ultrasounds for free. That's great. Oh, we got to train everybody. We got to pay them for training, and we got to do maintenance, and who sends them back, and what happens when they break, and so on, right? Next generation systems will provide a lot of data for us to examine, and especially important for research. So most medical directors and most fire chiefs have no idea what types of data are collected and tracked inside the communication center. And with next generation technology, there is tons and tons of data that could be teased out by the right person to have a valuable outcome there. Integration of the EMS data with the hospital data is really optimal, but very costly. I know today our EMS reports are PDF'd and added into the UW Medicine hospital records as sort of, PDF files, and not fully integrated into the data set. And that would be very, very helpful. And two-way data flow also lets EMS see outcomes of patients, lets the hospital and EMS exchange insurance and billing information. There's a lot of value to that. And it's been proven that you can do that and comply with HIPAA. The 8th item is about the situational awareness tools I talked about before, like that ED dashboard. And number 9 is the last one, is maintain awareness of how EMS calls are received, processed, and dispatched. You may think that medical care changes a lot with new drugs and treatments, and are we lifting the head up to intubate and things like that. But EMS communications changes every week. And you may think you know exactly how 911 calls flow and how your paramedics get those calls. But as an example, the Seattle Police Department can change their 911 policy for how they treat calls involving weapons, and they can have a completely unintentional downstream effect that delays the arrival of that call at Seattle Fire for EMS to be dispatched. So just because you know how the comm center works today does not mean that you know how the comm center works tomorrow. So an important takeaway there. And finally, I'm going to stop and leave some room for questions. I thank you for letting me come and talk. I could talk about all these topics, as Dr. Zayer knows, for at least an hour or more. And please know I'm just an email away if you want to go on a deeper dive with any of this. And I can't see the screen, so I don't know if there's questions already. Thank you, Dr. Zayer.
Thanks, Barry. Andy, are you on? Did we lose Andy? Maybe we lost Andy. That was quite helpful. Great overview of sort of the history of EMS communications. And one of the questions I had, Barry, was you kind of showed this situational awareness dashboard. And you indicated that was sort of something current technology could theoretically support. And I'm wondering, well, given that reality, how come it isn't actually there? Like, what are the sort of key, are there key barriers that people on this webinar could maybe chip away at?
Sure. Cost is always one. The computer-aided dispatch systems for all the EMS agencies in Seattle King County already have a lot of this data, excluding that patient physiologic alert. And so Portland, the Portland, Oregon metro area, they have, I believe, 7 communication centers, and they have a black box in the middle that translates all the disparate coding between those communication centers into common language, right? And so it doesn't matter if that call started in the Portland CAD system or the Clackamas CAD system. This translation box makes it common language. And so you need one of those common language tools so that an incident code from Seattle Fire that might be Med 7, it's translated into something that means something more legible or intelligible to a nurse, right? So,
Yeah.
so the data is there. Moving the data to the central point in the display is not hard technologically. CAD vendors like to charge a lot of money to do that. And I think this is really a place where you could maybe look for some grant funding or foundation funding to say, we want to do this as a trial to demonstrate the efficacy of it.
Yeah, I agree that certainly funding is the key barrier, a key barrier. And it's probably, at least in part, that the hospitals don't see a lot of value in consuming the information, and thus they aren't willing to pay for it. I mean, fundamentally, if it was really useful, they would presumably want to pay for this information because it would make them more efficient in some way. And because being more efficient is worth something to them, maybe that would work. But I suspect the underlying presumption that being more efficient is worth something isn't really that true.
Right, right. I mean, one spinoff is that a dashboard may make First Hill go on divert faster because they would see who is coming to them early before they arrived, right? So,
Yeah.
So technically there are no barriers. Even with the transmission of the physiologic data, that the barriers are not there. The question is, just because we can do it, should we do it? And is it helpful from a resource management perspective for an ED to be aware? As an example, if there's a major car crash and there are 7 patients and you start a low-level MCI, the hospital has an awareness that these people are coming in. I'm getting 7 backboarded patients from this call, right? But on a rainy Friday afternoon, AMR will bring you 7 patients simultaneously from 7 different accidents, but no one made a special phone call, right? So, so it's interesting in how we track some things and we don't track other things.
No, I agree, and I think part of this just reflects the maybe a little bit of the experiment hasn't really been done to show people like here's the real value in this, so they just don't know what they don't know,
Right.
and they could maybe be more efficient if they had this knowledge. But
and even a spinoff to an MCI situation. I mean, in MCI, we do patient tracking. We have an abbreviated way that we communicate numbers. WATRAC does that as well. So in an MCI situation, you have some awareness of that, and this would be sort of extending that in a more granular form to day-to-day operations.
well, it's interesting to me to kind of see these technology possibilities, and even simple things like getting sort of directions to the event that still don't work right in 2021 is kind of like sad. That's all I'm going to say.
It is, and I think the other the big takeaway really is also NG 911. And you look across the country, most 911 centers are understaffed. They don't pay well. They use a lot of overtime. They have burnout. A lot of times the person answering your 911 call has been on the job for like 5 months and just doesn't have a lot of experience. And now they're going to be having to react to the picture or the video of the house fire or the car crash or the robbery. And that's going to require a lot more training and just perhaps a higher level of individual to actually react to all that. And there's some studies that have said, you know what, EMS should push that stuff off to a third party and let a third party screen all this data information coming in for patient alerts, and then only ones that are screened out actually bounce back into EMS, rather than have EMS have to weed through all of this data coming directly to the 911 center.